I am Dr. S. Meenakshi Sundaram. I am a senior consultant neurologist working at Apollo Specialty Hospitals, Madurai. Thank you APICON organizers for having invited me for this talk on multiple sclerosis, what is the state of art in this wonderful pink city of Jaipur, where in fact I did my MD medicine training. Now what is this about multiple sclerosis? We all know by definition it is a demyelinating disorder which affects the central nervous system, involves multiple white matter tracts. Now earlier it was thought, in India it was not so common, but now we are increasingly recognizing this condition in our country as well. It was thought that it was only in temperate countries, but now even in our place we are recognizing more often. For instance, in Parsi community it has been being increasingly recognized. The incidence in India should be around 5 to 10 per 100,000 people. Now there are many clinical features which are suggestive of multiple sclerosis. The one which is very well known to us is the involvement of the eyes, vision, optic neuritis. We can also have many ocular motor pathway abnormalities like the internuclear ophthalmoplegia, various brainstem syndromes, cerebellar involvement, the motor fiber involvement, the sensory tracts involvement, and then we can have involvement of the bladder, bowel and sexual functions. Earlier we had some difficulties in diagnosing this condition because the criteria were so stringent. Now there are two important advancements which happened in this very exciting field. One is the criteria which have been newly evolved, the McDonald criteria, which allows earlier identification of this condition, which gives leeway for the physician to treat the patient aggressively from the beginning. And then when the introduction of interferons came into the market, this disease earlier which was untreatable overnight became one of the most exciting areas giving treatment opportunities in this field of immunology. So what is this McDonald's criteria revised in 2013, which allows more freedom for diagnosis? You need to have, obviously being a disease of relapsing remitting nature in the majority, you require 2 clinical attacks and you require 2 sites of involvement to be demonstrated, what we call as dissemination in space and dissemination in time, which should define the disease. Now if you have only 2 attacks but only 1 site which is demonstrated, you need to further demonstrate another site of involvement, which is today possible by looking at MRI, where again criteria have been evolved as to what are the sites that should be typically involved for us to call it as multiple sclerosis. What are these areas? The 4 typical sites of involvement are: 1, involvement of the cortical or juxtacortical region, periventricular regions, infratentorial involvement and the spinal cord involvement. These are the 4 typical sites for involvement. At least 2 sites should be involved for us to make a diagnosis radiologically to satisfy the criteria for multiple sclerosis. Now in a patient who has got only 1 attack, oligoclonal bands can be substituted as a substitute for dissemination in time. If a patient has got only dissemination in time, you have to demonstrate 2 sites. If the patient has got 1 site involvement, then you have to demonstrate involvement in 2 sites. If you have got involvement in only 1 site, you have to demonstrate 2 attacks for us to say this. So that is about the dissemination and the criteria. Now we have also now evolved criteria for diagnosis of the primary progressive multiple sclerosis as well. Now how do you treat these patients? Now for treating these patients, exciting opportunities are today available. We have the injectable therapies which came first, which includes interferon, then came glatiramer acetate, and then there are many oral therapies available. For instance, we have teriflunomide, then came dimethyl fumarate, now fingolimod and siponimod is entering the market. Then you have infusion therapies, highly effective therapies like the natalizumab, and then we have the ocrelizumab, and the new star in the horizon is ofatumumab. In India we are also using rituximab as an offline treatment. Now the patient can be effectively treated with highly effective therapies from the beginning for any aggressive forms in a given patient, and we can also assess the improvement radiologically. For instance, we can follow up patients, serial MRIs can be used to follow up to see for the improvement. We achieve what is called as no evidence of disease activity, NEDA, or if that is not possible, we can use at least minimal evidence of disease activity called the MEDA. Prognosis, how it is going to be, around 5 or 10% of people are really lucky, even without treatment they do well, but in the majority, if we do not treat them, it is going to progress. 1/3 of patients who have not been treated will develop significant disability in about 10 to 20 years. So, it is always wiser to treat them, and today with the exciting avenues available for treatment, this disease is more eminently treatable by all physicians. I invite you all to join us in this crusade against multiple sclerosis. Thank you once again. Namaste.